Welcome, everybody. This is Melissa Robinson. I have the pleasure of introducing our speaker today, Neil Chatterjee. Neil joined us. We were somehow able to recruit him away from Boston after 13 years there, getting both his MD and master's in epidemiology at Harvard and then staying on at Mass General for his training. And he came in the fall of 2019, which can only be rivaled as an unusual start by perhaps the fall of 2020. But despite the challenges, he's persevered to become one of our sought after ablationist clinicians and of course researchers. Those of you who've had the pleasure of catching his interest with your research will be rewarded handsomely, as he is highly productive and can lend insights into disease states and therapies, even to those of us who've been doing it for decades longer than he. So without further ado, I introduce Neil, who will be talking about rethinking sudden cardiac death, and I look forward to learning from him.
Excellent. Thank you very much, Melissa. Good morning to everyone. I'm obviously delighted to be here. Thank you to the Grand Rounds organizers for the invitation and the opportunity to share with you some of the work that we've been doing. So without further ado, I'll just dive into the talk. The talk today is going to be about rethinking sudden cardiac death, exactly as Melissa mentioned. I have no disclosures that are relevant to the content of this talk. So just by way of outline, I thought I'd organize the talk into three parts. Part one is going to be taking stock of where we are today in terms of our conception and formulation of risk, not just for sudden cardiac death, but in general. In part two of the talk, I'll move to comment and share with you some of the work that our group has been doing in the arena of competing risk. And I'll try to talk to you about that work in the context of two stories, which I'll share with you. And then I'll end the talk in part three, also describing and sharing with you some of the work that our group has been doing, evaluating novel approaches to risk stratification and prediction. So sudden cardiac death, as all of you know, is certainly a major public health scourge. The annual incidence is about 300,000 in the US. It turns out that it's pretty hard to actually specifically estimate both the domestic and global incidence of sudden death, and a lot of that has to do with the infrastructure available for sort of phenotyping that sort of specific endpoint. But suffice to say that hundreds of thousands of folks die of sudden cardiac death every year in this country. Sudden death, importantly, is the first manifestation of cardiovascular disease in about 40% of people. And so from a public health, from a scientific, from a biological perspective, that's a major challenge, right? I mean, nearly half of patients who ultimately experience a mortal endpoint have no prevalent history or diagnosis of cardiovascular disease. So how do we think as cardiologists about identifying and predicting who is likely to experience this sort of terrible endpoint? And then as an extension of that, of course, how do we think about deploying preventive strategies in that high-risk population? At least in this country, coronary disease is the most common underlying substrate, and that's generally true around the world. One of the challenges of preventing and predicting sudden cardiac death is highlighted by this graphic, which was put together by Bob Meyerberg, who's now towards the end of his career. This concept has been around for a long time. And Bob's point was that there are clearly high-risk subgroups, folks that all of us take care of every day. High-risk subgroups, folks with a low EF, folks with heart failure, folks with a documented history of cardiac arrest, folks who clearly qualify in our contemporary formulation for a primary prevention ICD. The reality, though, is that even though the proportional risk of sudden cardiac death is very high in that group, on an absolute scale, those events only comprise a small percentage or a small proportion of all of the sudden cardiac deaths in a given year. And so from a public health perspective, even though we are deploying ICD therapy, for example, in these high-risk subgroups, we're not really impacting, and we have not really impacted overall rates of sudden cardiac death for years. And the reason for that, again, is that the vast majority on an absolute scale, the vast majority of these sudden cardiac death events are happening in patients in whom there's no consensus on prediction or prevention. And so a lot of folks, or some folks, have been interested in potentially looking at markers in the general population that might identify, folks, sort of 40-year-old that has no prevalent cardiovascular history who all of a sudden drops dead while, biking on the Burke-Gilman. Folks have been interested in identifying risk markers or some parameter that we might be able to identify and pull out to identify that sort of healthy, that healthy person who ultimately experiences a sudden cardiac death event. But from my perspective, I think that strategy as a public health intervention is not likely to be particularly effective. And the reason for that is that the absolute rate of sudden cardiac death in the general population is exceedingly low, about 0.01 to 0.03% per year. And so even if you picked a perfect risk marker, a marker, say, with a hazard ratio of 2, or frankly, even 3 or 4, you're only going to enrich risk on a very nominal scale. And so what my group and lots of groups around the world have made the case for is that if we're going to be thinking about risk stratification, if we're going to want to make a dent in the public health sort of burden of sudden cardiac death, where we should at least start our efforts is in this green group. These folks who are not quite the general population, not quite folks who qualify for a primary prevention ICD, but folks who are otherwise deemed high risk, somebody in whom, if you were able to enrich for risk, you might then yield sort of an actionable rate of sudden cardiac death over a reasonable timeline. And so a lot of the work that I'll be sharing with you today involves cohorts of patients, say, for example, with cardiovascular disease, coronary heart disease, and ejection fractions north of, say, 35 to 40%, a group that we know is at higher risk than, say, the general population, but who also don't qualify, for example, for a primary prevention ICD. So in terms of where we are today with risk stratification, I thought a straightforward way to evaluate that would be to take stock of the risk stratification schemes that we use all the time. So the CHADS-2 VASC score is a score that we've all deployed in conversations with our patients about the role of anticoagulation for AFib. For those of us who take care of patients with hypertrophic cardiomyopathy, we often find ourselves Googling the HCM risk calculator, which provides an absolute risk of sudden death at 5 years and provides some recommendations, at least by the European guidelines, for who qualifies for something like a primary prevention ICD. And it's, of course, hard to give a talk here at this institution without at least sort of mentioning the Seattle heart failure model, which, as all of us know, is a multi-parametric model that provides annual mortality estimates for our patients with heart failure. So I'd like to try to make the case that all of these risk schemes have 3 primary characteristics. The first is dichotomization, either of the risk markers that are going into the score or as a function of how we make a decision. So for example, for the CHADS-2 VASC score, the questions that we're asking are yes or no questions. Does this patient have a history of hypertension? Does this patient have a history of stroke? In terms of the hypertrophic cardiomyopathy calculator, our decision is being dictated by a yes or no type of phenomenon. Is the 5-year rate of sudden death greater than 5%? If yes, then an ICD is advised. If no, then an ICD is not advised. The other reality for all of these risk tools, and honestly, for all of the decisions that we make for patients, is that we're deploying these risk tools and we're making these decisions in a cross-sectional manner at that moment in time. And then finally, all of these risk scores, be it the CHADS-2 VASC score, be it the hypertrophic cardiomyopathy calculator, are exclusively operating in an absolute risk paradigm. So if your absolute risk of stroke per year is greater than 2 or 3% per year, we think you qualify for an anticoagulant. If your absolute risk of dying of sudden death is more than 5% at 5 years, we think you qualify for an ICD. So I'd like to think a little bit about how those sort of core characteristics serve us or don't serve us well when we're trying to think about stratifying for the risk of sudden cardiac death. So what about this notion of dichotomization? Well, I think all of us can appreciate from a biological perspective that risk is much more likely to exist on a continuous spectrum as opposed to a dichotomous spectrum. And so here are data that I'm showing you that we published in JAMA Cardiology a few years ago, looking at patients with a history of coronary heart disease and an ejection fraction greater than 30 to 35%. And we asked a very simple question: what is the relationship between left ventricular ejection fraction and the risk of sudden cardiac death? And if you reference a normal ejection fraction, you can clearly see that as you go down the ejection fractions spectrum, there's a clear and continuous rise in the risk of sudden cardiac death. So this notion in our contemporary consensus guidelines that there's sort of something magical about an EF of 30 or 35% is just not true on a biological scale. We also know in a challenging way that the same risk marker could operate optimally in a dichotomous fashion for some substrates, but not for others. So here I'm showing you a nice paper from Halliday and colleagues published in Circulation a few years ago, looking at the role of scar based on cardiac MRI as a way to predict an adverse cardiac outcome. And so again, these are patients with dilated non-ischemic cardiomyopathy, EF greater than 40%. And these authors found that dichotomizing scar as yes scar or no scar was the best way to distinguish risk in this particular substrate. And to credit the authors, they did look carefully as to whether or not there was a dose response relationship. And what they found was that the optimal C statistic, which is the optimal trade-off of sort of sensitivity and specificity, was in fact just, was there scar or was there not scar? Well, what if we look at the same risk marker, LGE, but now in hypertrophic cardiomyopathy? These are data that were published in the Journal of the American College of Cardiology a few years ago. And here we find actually that the optimal cut point for LGE and hypertrophs is totally different. Here we see a clear curvilinear type of relationship that has an inflection point around 20%. So even if we find a great risk marker, what makes it more challenging is, again, this notion that perhaps the risk marker for some substrates could be modeled or optimized as a dichotomous variable, but for other substrates, not so. What about this notion of cross-sectional assessment? Well, we've known for a long time that the risk of sudden cardiac death is not static. These are data from an old mentor of mine, Scott Solomon at the Brigham, published in the New England Journal. This was a post-hoc analysis of the Valiant study, a large trial of patients with a history of myocardial infarction. And Scott asked a very simple question. They just modeled what was the absolute rate of dying of sudden death in the months after a myocardial infarction. So time zero here was your heart attack. And they just looked over time and they estimated each month your rate of dying of sudden death. And they happen to stratify here by your left ventricular ejection fraction, but it doesn't really matter which curve you follow. Clearly, you see that there's a higher risk of sudden cardiac death in the first 3 months after a myocardial infarction, which then sort of levels off to a more basal rate as you get beyond 1 year. And the same observation was made in patients who have an ICD. These are really old data now from Wood and colleagues more than 25 years ago, where they just looked at the time between ICD therapies. And so if you estimated or predicted, or if the time between ICD therapies was the same, you would expect a curve that looks like this dashed line. And what instead you see is a curve that looks like this dark line, which is to say that there's clear clustering of ICD therapies in our patients who have ICDs. And for all of us that take care of patients who have ICDs, we know that this is true. We have our heart failure patients, our ICD patients who do well for years, and then all of a sudden sort of present with storm or sort of a cluster of ICD therapy. So we know that that risk is dynamic. We know that risk can be transient. And so how does that impact our ability to predict and be flexible in our formulation of risk for our patients? And finally, what about this notion of absolute risk? So absolute risk has really dominated the field of the prediction and prevention of sudden cardiac death for years. I'm showing you here now rates of annual mortality in a range of very famous ICD trials that all of you well know. So Made It 1, Made It 2, and SCUD-HEFT CHARM happens to be a heart failure trial. And I'm showing you total rates of mortality in gray, cardiovascular mortality in blue, and sudden cardiac death mortality in red. You'll appreciate certainly over time, we got better at taking care of these patients. And so rates of all kinds of mortality went down. But a major point that has been gleaned or has been argued from these ICD trials is if you look back, say, at any ICD trial that was, quote, positive, so any ICD trial that showed a survival benefit, be it Made It 1 or Made It 2 or SCUD-HEFT, all of those trials had an absolute rate of sudden cardiac death of more than 3% per year. And so for years now, people have made the case that if you're going to design an ICD trial that's going to show an ICD survival benefit, all you need to do is find a population of patients who have an annual rate of sudden death more than 3% per year, and voila, you'll find an ICD trial that will save lives. But we know that that's not true. So for example, I'm showing you data here from the IRIS study, which was a very famous study that all of you are well aware of, looking at the potential role of ICD therapy right after a myocardial infarction. And if in fact you look at the rate of sudden cardiac death in the control group of that trial, it was 3% per year. And sure enough, if you looked at the impact of an ICD on rates of sudden death, the ICD did what we expect it to do. It drops the rate of sudden cardiac death in half. But IRIS was a famous trial, just like Dynamite, not because of this finding, but because of this finding. There was no difference in overall mortality with ICD therapy as compared to not. And the reason for this, of course, has to do with competing risk, which we'll talk more about in part 2 of the talk. So if we regroup here and talk about again where we are today with risk stratification. As we think about this concept of dichotomization, we know that a lot of the risk markers that we're using to stratify for sudden cardiac death exist on a continuous spectrum, not a dichotomous spectrum. And in a very challenging way, the same risk marker might operate optimally dichotomously for some substrates, but not for others. In terms of cross-sectional assessment, we know that risk is dynamic and clustered. And so how do we think about formulating our risk paradigm to be sort of responsive to that sort of reality? Can we do a better job of capturing those risk transients? And finally, as we sort of think about this notion of absolute risk, I don't mean to suggest to you that absolute risk doesn't matter, but I'd ask us to think carefully about what type of absolute risk we are taking stock of. How do we understand this notion of competing risk, and what are the implications of competing risk for our patients? And so that's a nice segue into part 2 of the talk, which again is about this notion of competing risk. And I'm going to share with you some of the work that our group has been doing in the context of 2 stories. The first story is titled "Competing Risk is Hard to Get Away From," and the second story is titled "Higher is Not Always Better." So we know, and all of you know, that patients at risk for sudden cardiac death are also at risk of dying of other stuff. That has major consequences for our patients. It means, for example, that the majority of our patients who undergo a primary prevention ICD are likely to never receive an ICD therapy over the course of their lifetime, which is to say that they're more likely to die of something else as opposed to being shocked or having ATP from their ICD. In a provocative paper that Dan Kramer, a former colleague and friend from Boston, published in Circulation a few years ago, they looked at a Medicare population undergoing primary prevention ICD therapy, and Dan and his colleagues found that more than half of those patients had either died or were enrolled in hospice in 5 years after their ICD implant. So clearly, we as a community can be doing a better job of identifying patients who stand to benefit from things like an ICD. What are the implications of competing risk for all of us? So it depends on who you are as a stakeholder. If you're a clinical trialist, competing risk means performing and designing and investing a lot of time and effort in ICD trials that lower the rates of sudden death, but have no impact on overall survival. There's lots of high-profile examples of that: Dynamite, IRIS, Danish, for example. If you're a patient, it means undergoing a procedure and having a device that has both short and long-term risk in terms of lead malfunction, the risk of inappropriate shock, and it's experiencing and exposing yourself to all of those risks without really any extension of survival. And if you're a healthcare system, it means investing lots of time and effort into the massive sort of structures that are required to take care of these patients, not just the cost of the procedure itself, but the expenditures in terms of hospital follow-up and outpatient follow-up and device clinic and monitoring platforms, and investing in all of that without actually executing or deploying a technology that's improving the quality or quantity of a person's life. And so how do we think about modeling competing risk in a smarter way? So the first story I'm going to tell you is competing risk is hard to get away from. So to do this, we thought we would try to be a little bit more quantitative when it came to understanding and modeling competing risk. And so we took a population of patients with heart failure. These data are from the CHARM study, which is an old study run by Mark Pfeffer and Scott years ago, looking at the role of ARBs and ACE inhibitors in heart failure. So that alone will tell you how old the trial is. And in that trial, we generated cause-specific models for types of death. So we generated a model for your probability of dying of sort of sudden cardiac death. We generated a model for your probability of dying of heart failure death, and we generated a model of you dying of any other kind of death. And so each one of these blue dots is one person in that trial. And on the y-axis is that person's probability for your probability of dying of sudden cardiac death. And on the x-axis was their probability of dying of a competing mode of death. The red line here is the line of unity, where your probability of dying of sudden cardiac death was the same as the probability of dying of competing death. And so you'll just notice, before even taking stock of any numbers here, you'll notice two big things on this slide. The first is, there's clear correlation between the y-axis and the x-axis, right? These dots are clearly clustered. This is really dark and dense and blue. And so if you wanted to sort of think about that quantitatively and just looked at the Spearman correlation coefficient, you would find that the probability of dying of sudden death was strongly correlated with the probability of dying of heart failure death, probability of dying of other deaths. And if you just put all competing mortality together, correlation coefficient was greater than 0.9. You didn't need the Spearman correlation coefficient to tell you that. You could just look at this graph. The other thing that you'll notice clearly is that most of these dots fall below the line of unity, which again is the lived reality for all of our patients who are undergoing, say, for example, a primary prevention ICD. Patients are more likely to die of other stuff as opposed to dying of sudden cardiac death. So how can we use this correlation concept to enhance our understanding of risk stratification? Well, if we just put our sort of optimal scientific hats on, and we said, well, if we were to find the optimal risk marker to stratify patients for preventive therapies for sudden cardiac death, I'd like to make the case to you that what we'd want to find is a marker that has green-like properties, a marker that would take any one of these blue dots and push that blue dot up the y-axis, so increase the probability of sudden cardiac death, but have no impact on the probability of competing death. You could also imagine a blue-like marker, a marker that could, say, disqualify somebody from an ICD, taking any one of these blue dots, increasing the risk of competing death with no impact on the risk of sudden cardiac death. And you could also imagine a red-like marker, a marker that increases the probability of dying of sudden cardiac death, but also increases the probability of dying of competing deaths. And what I'll try to convince you of is that most of what we have in contemporary practice are these red-like markers, markers which at the end of the day are not particularly helpful in enhancing or advancing our formulation of risk stratification. So we try to look at this. We try to look at these properties, these green-like properties, blue-like properties, and red-like properties in patients with coronary heart disease and relatively preserved ejection fraction. So these are data that were published again in JAMA Cardiology a few years ago. And here I'm showing you a variety of possible risk markers: age, sex, race, smoking, hypertension, family history, diabetes, AFib. And here I'm showing you the relationship between that risk marker and the association with the risk of sudden cardiac death, shown in orange, and the risk of competing death, shown in blue. The p-values here are derived from something called competing outcome models. So the p-value is testing the differential association of the risk marker with one outcome as compared to the other. So for example, if you focus here on the bottom of this graph, you find here that diabetes is associated with a doubling of the risk of sudden cardiac death. Same in fact is true for AFib. But you also see that diabetes and AFib are also associated with a doubling of the risk of competing mortality. So when you look in a competing outcome model, there's no significant difference for the association of diabetes or AFib with one death type as compared to the other. So diabetes and AFib would be red-like markers, markers again that push one of those blue dots just up the diagonal. Conversely, as you might expect as a positive control, age was a blue-like marker. Clearly, as folks got older, there was an 8-fold gradient of risk as it pertained to the risk of competing mortality, not much of a change in terms of the risk of sort of sudden cardiac death. And so, as you might imagine, there was a differential association of older age with one death type as compared to the other. What about left ventricular ejection fraction and heart association class, the two cornerstones of our guidelines for primary prevention ICD implantation? Well, if you look, for example, in the lowest strata of ejection fraction or the most advanced strata of heart failure, clearly strong associations, 3 to 5-fold associations with the risk of sudden cardiac death, but you also find really strong associations with the risk of competing mortality. And so really low ejection fraction in advanced heart failure, red-like markers, again, markers that increase the probability of both death subtypes. By comparison, if you looked at milder abnormalities of ejection fraction, here you're starting to find possibly a green-like marker, a marker that quadruples your risk of sudden cardiac death, only doubles your risk of competing deaths. And so here there was a differential nominally, but there was a differential association of mild ejection fraction abnormalities with the risk of sudden death as compared to not. And mild heart failure had the opposite property, a doubling of the risk of competing mortality, no change in the risk of sudden cardiac death mortality. And so mild heart failure or class 2 heart failure possibly could operate as a blue-like marker. So if we map those findings onto this paradigm, what I'd like to try to convince you of is that most of what we have today in terms of ejection fraction or diabetes or AFib or advanced heart failure, red-like markers, markers that push any one of those blue dots up the diagonal. We did find some blue-like markers, including older age, and sure, you could come up with a more complicated approach and have a complicated model that modeled things like sort of frailty. And I would be almost confident that something that does a great job of capturing sort of frailty would be a blue-like marker. And that is already sort of integrated into our guidelines. If we anticipate that a patient is not likely to survive more than a year, we generally say that they should not undergo ICD implantation. What we don't have, and what is a major knowledge gap, are green-like markers, markers that, again, increase the risk of the probability of dying of sudden death, but have no impact on the risk of competing death. And as a teaser, I'll tell you to wait for part 3 of the talk to think about what those green-like markers might be. So before we're getting to part 3, though, I want to tell you another story about competing risk titled "Higher is Not Always Better." And for fans of Spinal Tap, you'll get the dial sort of reference on the left. And for fans of not Spinal Tap, I'll point out that the Space Needle, which is a classical part of our skyline, as I learned after moving here, is only the 8th tallest sort of building in Seattle. So why is higher not always better? To answer that, I want to go back to that graph that I showed you at the beginning of the talk in part 1, which looked again at annual rates of total mortality and cause-specific mortality in ICD trials. Here, I've just added a couple of cohorts, the Danish study and the predetermined study. Predetermined, again, was a cohort of coronary heart disease and an ejection fraction greater than 35%. Danish, as all of you know, was a randomized trial of primary prevention ICD therapy in non-ischemic cardiomyopathy. And as you can see clearly over the course of 20 years, we have gotten better at taking care of our patients with cardiovascular disease. Rates of all-cause mortality and cause-specific mortality have certainly gone down over time. And so in light of the negative findings of a trial like Danish, people have asked the question, can we just take the Danish population, for example, and find a subgroup that, using a risk marker, that increases the risk of sudden cardiac death over this sort of magical 3% per year threshold? And can we then use that as an inclusion criteria to identify and execute randomized trials to then yield a survival benefit for something like ICD therapy? Can we just take our contemporary cardiovascular populations, find a risk marker, identify an absolute risk cut point, and then again use that as our driving paradigm for how we identify patients who could potentially be candidates for sudden cardiac death prevention? Well, let's just think about that as trialists. So when we're designing a clinical trial and a cardiovascular outcome trial, I'd like to make the case that every cardiovascular outcome trial has 2 primary endpoints. And so I happen to pick this trial here, which is transcatheter mitral valve repair for patients with heart failure. And if you looked at the top line results of that trial, you'll see that the investigators make 2 comments about their primary outcome. The first was the hazard ratio for all-cause mortality, and the second was the number needed to treat to save 1 life. And so if you unpack that a little bit further on a mathematical basis, the hazard ratio for all-cause mortality is a function of the death rate in the control group minus the death rate in your treatment group divided by the death rate in your control group. For number needed to treat, it's 1 over the absolute risk reduction. And so if we're going to be designing an ICD trial and we assume that there's no impact of an ICD on competing mortality, and that's a nuanced point that may or may not be true in every population, but if we assume that there is no impact of the ICD on competing mortality, mathematically, the hazard ratio for all-cause mortality is a function by definition of the proportional risk of dying of sudden death. By comparison, the number needed to treat to save a life is only a function of absolute risk. And I'll share with you some of the work that we've done to sort of explicate that a little bit further and try to convince you of why that matters. So we looked again in the predetermined study, patients with coronary heart disease, relatively preserved ejection fractions, at what would happen if we designed a clinical trial just based on left ventricular ejection fraction in patients with established cardiovascular disease and coronary heart disease in particular. And so if you look, for example, across strata of ejection fraction, you saw a 5-fold gradient of risk over 4 years for the probability of dying of sudden cardiac death. Fantastic, you might say. What we also looked at, though, was the proportional risk of sudden cardiac death. So what you also see is that ejection fraction is really, really good at stratifying for competing death. And in fact, the absolute rates of competing death dwarf the absolute rates of sudden cardiac death. And so if you looked at proportional risk now going down the ejection fraction spectrum, you see that because left ventricular ejection fraction is correlated with the risk of sudden death, as well as the risk of competing death, the consequence of that is that we have now uncoupled absolute and proportional risk. You might say, okay, who cares? Well, what happens when you uncouple absolute and proportional risk is that you uncouple the concepts of risk reduction for all-cause mortality and the number needed to treat to save one life. So here we are now modeling an ICD trial based on a range of inclusion criteria. So these are patients, again, cardiovascular disease, established coronary heart disease. And we asked the question, what if you ran an ICD trial just based on this inclusion criteria? So it could be ejection fraction, it could be age, it could be atrial fibrillation, could be diabetes, could be advanced heart failure. And we modeled the number needed to treat to save one life with an ICD. And we just lined up all of these subgroups from left to right, from lowest absolute risk to highest absolute risk. And what we found, which is a mathematical truth, is that as the absolute risk of sudden cardiac death went up, the number needed to treat to save one life with an ICD went down. And so if you took patients with established cardiovascular disease and coronary heart disease and advanced heart failure, for example, we would estimate that you would need to have a trial would show a number needed to treat of 31 to save one life with an ICD. You might say, now, fantastic. Well, what about the other top line result of that paper, which is the hazard ratio for overall survival? So I'm showing you again, the same subgroups organized in the same way, lowest absolute risk to highest absolute risk. And now I'm showing you the percent reduction of overall mortality with an ICD. Again, all of this is modeled. But what you see here is that there's now no relationship between absolute risk and the estimated risk reduction for all-cause mortality. If you instead looked at proportional risk, you find that the percent reduction for overall mortality is exquisitely sensitive to the proportional risk of sudden cardiac death. So for example, if you looked at young people, somebody less than the age of 60 with a history of established coronary heart disease, half of their mortality, half of the reason they're going to die is the risk of sudden cardiac death. And so in that population, you would anticipate a hazard ratio of 0.7, a 30% risk reduction in all-cause mortality with an ICD in that population. By comparison, if you picked your sort of classical high-risk subgroup, folks with a low ejection fraction or folks with advanced heart failure, you would expect a very modest hazard ratio of sort of around 0.9 with a risk reduction, again, of around 10% for the prevention of all-cause mortality. So what does this mean from a public health strategy perspective? So if you're a health system, if you're a government, if you're a health organization, if you deploy a strategy exclusively focused on absolute risk using contemporary risk markers, which are correlated with both the risk of sudden death and competing death, that translates certainly to enriching for a higher absolute risk of sudden cardiac death, but it also means that only a modest impact of the ICD on overall survival. By comparison, if you deploy strategies that are focused on proportional risk, so for example, targeting younger patients with established coronary heart disease, you start to identify, again, on an absolute scale, perhaps their absolute risk of sudden death isn't that high, but for that patient, the impact of the ICD is estimated to be much greater. So I want to now leave part 2 of this talk and move on to part 3 of the talk, which is to share some of the work that our group has been doing to now move beyond the contemporary paradigm of risk stratification. And so what is the future of risk prediction and trial design? And I want to comment and talk about basically 2 big topics. One is our work to improve the specificity of our risk markers, and 2 is to move beyond this absolute risk paradigm. So to sort of return to this sort of organizing graphic, if you will, I tried to make the case to you in part 2 of this talk that risk is clearly correlated. Most of what we have today, be it ejection fraction or diabetes, operate like red-like markers, markers that increase the probability of both death subtypes. We have some blue-like markers, but a major knowledge gap, a big question mark in our field, are these green-like markers. What are these markers that increase the risk of sudden death, but have no impact on the risk of competing mortality? And so as an electrical cardiologist, one of the things that I was intrigued to examine and to look at was, is it possible that electrical markers that are more specific to the electrical sort of functionality of the heart, is it possible that those markers might be more specific to capturing the risk of dying of sudden death as opposed to the risk of dying of competing death? There's been a lot of interest in the cardiovascular field in general about the potential association between myocardial inflammation and the risk of ventricular arrhythmias, and I'll share with you some of the work that we've done to look at that. And then finally, the role of cardiovascular genetics. Are there ways in which we can leverage the genome to specifically identify the risk of sudden death as opposed to other kinds of death? And so our contemporary paradigm is shown here. These are this is a graphic from Jeff Goldberger, who's a colleague and friend, chief of cardiology at the University of Miami. And Jeff, years ago, put this paper together in Circulation Research, and he makes the case here that our current risk paradigm is this. Basically, we take a population at risk, we measure their ejection fraction. If their EF is less than 35%, we call them low risk. If it's greater than 35%, or high risk rather, and if it's greater than 35%, we call them low risk, and we deploy our sudden cardiac death prevention strategies. Jeff's point was, can we be smarter about that? Can we identify risk markers organized by complementary domains of, say, electrical risk, combine those markers to specifically enrich for the risk of sudden cardiac death? So can we identify risk markers that are more proximal to the causal biology of ventricular arrhythmias, right? So as I think about ways to find these green-like markers, as we sort of thought about ways to specifically identify these risk markers, the notion was, can we start as a matter of first principle in the causal pathway from ventricular arrhythmia to sort of sudden cardiac death, a risk marker to sudden cardiac death? Where can we go back further in the causal pathway to be a little bit more specific than, say, diabetes or ejection fraction or heart failure, which certainly exist in that causal pathway, but have lots of other causal arrows to other things like heart failure mortality, which can be problematic. So one of the tools that we thought about looking at was the 12-lead EKG. We thought about looking at the 12-lead EKG because the 12-lead EKG is a low-cost tool that can be deployed in multiple healthcare settings, specifically and particularly in a global health setting. So, if we're thinking about making a dent in the global public health burden of sort of sudden cardiac death, we need to be able to find risk markers that don't include things like having a cardiac MRI, for example, which is something that's not going to be deployed in a low resource setting. So can we find easily measured, low cost, easily deployed risk tools to be able to predict and enrich for the risk of sudden cardiac death? So we started with the EKG, and the EKG potentially, we thought, captures lots of types of risk that might be germane to the risk of dying of sudden cardiac death. So there are certainly EKG markers that capture anatomic factors, be it scar or hypertrophy, that might be pertinent to the pathophysiology of dying of a ventricular arrhythmia. There are certainly global parameters that could capture autonomic perturbation, which we know has sort of real relevance in the pathophysiology of dying of sudden death. There are clearly depolarization markers like QRS duration or QRS fragmentation that might be important. And then, of course, repolarization markers like a long QT interval or T-wave inversion. And so we basically looked at each of these markers organized by risk domains, and we modeled the association of those risk markers with the risk of sudden cardiac death. But we did two important things. In our risk models, we explicitly, in a prospective, pre-specified way, accounted for the risk of competing death. And we also adjusted for standard contemporary risk markers, including things like ejection fraction and heart failure. And what we found were 4 markers, 2 markers of anatomic risk, LV hypertrophy and contiguous Q waves, 1 depolarization marker, QRS duration, and 1 repolarization marker, a prolonged JT interval. And we found robust associations between each of those markers and the risk of sudden cardiac death. That was true even after you accounted for competing risk, and even after you adjusted for all the things that you might care about, including age and sex, race, hypertension, diabetes, ejection fraction, heart failure class, and beta blocker use. Strong associations of all these markers with the risk of sudden death, adjusting for clinical risk factors, and even when you adjust for all the other EKG factors, again, strong associations. We scaled all of those risk markers into a point score. We organized that point score into low, moderate, and high risk subgroups, and we looked in a derivation and validation cohort at absolute rates of sudden death organized by EKG risk score. These cohorts are patients with established coronary heart disease and relatively preserved ejection fraction. So exactly that sort of moderate risk group where I've tried to make the case that risk enrichment matters. And these are data that we published last year in the European Heart Journal. And what you see here is that in the high risk subgroup, just on the basis of using this low cost, easy to deploy EKG risk tool, that in the high risk subgroup over the course of 5 years, you start to see absolute rates of sudden death that are actionable rates of sudden death that are the exact same rates that we currently apply to qualify patients for primary prevention ICDs, for example, in hypertrophic cardiomyopathy. Now, you might say, Neil, you just spent the last 20 minutes harping on this notion that we have to think more than just absolute risk. So how does this risk score operate in terms of its sort of performance as it relates to the prediction of sort of sudden cardiac death as compared to competing mortality? So I'm showing you those data here. So organized here again, low risk, moderate risk, high risk by EKG score, derivation cohort in solid lines and validation cohort in not solid lines. And we're looking at the association of the risk score with competing mortality in blue and the risk of sudden death in red. So if you just focus on the high risk subgroup, what you see here in both the derivation and validation cohort is more than a tripling of the risk of sudden cardiac death with no real change, a modest increase in the risk of competing mortality. And so from a sort of foundational kind of sort of methods perspective, the other argument that we make in this paper is that if we're going to be identifying risk markers from a sort of methodology perspective, we need to be able to explicitly integrate competing risk into the derivation of our risk modeling. And we make the case here as a proof of principle that if you explicitly incorporate competing risk in the soup of actually finding your risk marker, you can start to identify risk markers that work on an absolute scale, but also work on a sort of competing risk scale. So markers that, again, specifically increase the risk of sudden cardiac death, but don't increase the risk of competing mortality. All right. As a final point, we then went through the mental exercise of looking at how the EKG score operated across quartiles of sort of clinical risk. And you clearly see here on the y-axis small print, we're just sort of looking at absolute rates of sudden death, but clear gradations of risk regardless of the clinical quartile that you're looking at. As you have a higher and higher EKG risk score, you have a higher and higher risk of dying of sudden death. And we then went through the mental exercise of actually estimating what would happen if you designed an ICD trial just based on this EKG score. And so if you had patients with coronary heart disease and a high-risk EKG score, we would estimate a more than 15% risk reduction in all-cause mortality with ICD therapy. And if you wanted to know what sort of sample size you would need to find that sort of mortality benefit, it's about 4,000 people. So a trial that could be performed and deployed in a reasonable fashion. If you combine the high-risk EKG score with a low normal ejection fraction, we would estimate more than a 20% risk reduction in all-cause mortality, and you would only need a trial of around 3,000 participants to be able to show with 80% power that type of risk reduction. So now we're starting to make the case that, again, explicitly incorporating competing risk with specific markers leads us to be able to design and deploy and execute trials that are feasible in contemporary practice. All right, so moving beyond EKG markers, what are some other markers that our group has looked at that potentially could be more specific to the risk of sudden cardiac death? One of, there's been for now, sort of many years, a lot of interest in looking at markers of inflammation and fibrosis as they pertain to the risk of dying of sudden cardiac death. So in collaboration with colleagues, friends, and collaborators at Mass General, we looked at the role of circulating microRNAs, which have been emerging biomarkers for both ventricular remodeling and ventricular arrhythmias. And in a case control cohort of patients with established coronary heart disease, we found 3 particular microRNAs, 150, 29A, and 30A, that were clearly associated with a greater odds now of the risk of dying of sudden cardiac death. These are data that we published in JACC EP last year. And we scaled these into an miRNA score. And as you might expect, the greater numbers of abnormal microRNA values that you had, the higher the probability of dying of sudden cardiac death. Folks with abnormal levels of all 3 had a greater than 5-fold odds of dying of sudden death as opposed to not. And so then we sort of went the next step and looked at an ontological pathway analysis, and all of these microRNAs are implicated in pathways that are related to either inflammation or fibrosis. And so these data are now serving as the basis for the ongoing design of a prospective biobanking protocol that's going to be shared between us and Mass General, looking at patients with ventricular arrhythmias, PVCs, and VT, with the hope of potentially being able to identify microRNA sort of signatures that are specific to the risk of sudden cardiac death and ventricular cardiac arrhythmias. So what about inflammation and fibrosis? There's been lots of really exciting work looking at the potential role of cardiac macrophages and cardiac immune cells in both the homeostasis and pathophysiology of abnormal electrical function. This is a graphic that was put together by former colleagues of mine at MGH, published in Nature several years ago, looking at the role of cardiac macrophages and crosstalk between cardiac myocytes and macrophages in the AV node in sort of dictating or maintaining the shape of the cardiac action potential. And so we've been interested, and I've been interested in collaboration with Dr. Stempian Otero, whose group has clear expertise and has done sort of really beautiful work evaluating the role of cardiac immune cells in heart failure. We are now investigating the role of cardiac macrophages and cardiac macrophage sort of phenotype in their association with the risk of ventricular arrhythmia. So these are data that Steve Ferris and April put together that were published in a really beautiful paper in JACC a few years ago, looking at transcriptional changes of fibrotic and inflammatory genes in cardiac macrophages before and after unloading in the context of an LVAD. And so we are now looking with the sort of direction of April at the relationship of macrophage sort of phenotype, again, both pro-fibrotic and pro-inflammatory, with the risk of ventricular arrhythmias in patients with advanced heart failure. This work has potential diagnostic, risk stratification, but also sort of therapeutic implications, because we now might start to think about the role of modulating the immune system as an anti-arrhythmic strategy to be able to modify risk in our patients, say, with advanced heart failure. I'm going to end at least this part of the talk by talking about sort of briefly about genetics. There's been a lot of excitement and a lot of interest in using cardiovascular genetics to predict potentially the risk of sudden cardiac death. On the left, I'm showing you data from a good friend of mine, Amit Kara, who's at Mass General, who put a nice analysis together in JACC a few years ago, looking at pathogenic variants in the general population. And Amit and his colleagues, and Nana was on this paper as well, looked at or found that pathogenic variants related to cardiomyopathy, coronary disease, long QT, ARVC, and aortopathy were associated with a threefold increased risk of cardiovascular death as compared to not in a general population. On the right, I'm showing you really beautiful work from Nana's group published in the European Heart Journal a few years ago, where they looked also at the general population, finding associations in variants that were implicated in the QT interval and AFib and the risk of sudden cardiac death. We've also looked at this in the predetermined study. These are data that are currently under review at the moment, under review at a journal, where we looked at the relationship between a polygenic risk score for coronary artery disease. So now we're sort of summing risk across the genome. And so we derived the polygenic risk of coronary artery disease in patients with established coronary artery disease. And we looked at the relationship of polygenic risk and the risk of sudden cardiac death as opposed to competing modes of death. And we looked at the top decile of polygenic risk as compared to not. And what we found in a really exciting way was that patients at highest polygenic risk of coronary disease had more than a doubling of the risk of sudden cardiac death now over 8 years as compared to the rest of the cohort. And there is no difference in the risk of competing mortality. So now we're finding not just on a sort of single gene variant scale, but on a polygenic scale, we're finding that we can potentially identify these green-like markers. So to now return to this, sort of organizing graphic, the work that our group and groups around the world are doing is, I think, hopefully advancing this paradigm, hopefully finding green-like markers, be they low-cost deployable tools like an EKG, higher-cost, more complex tools like polygenic risk, and potentially some intriguing work sort of looking at either biomarkers or cardiac sort of macrophages that might be able to specifically identify, again, the risk of sudden death as opposed to not. So I'm going to end the talk. I'm going to take stock of time here, 8:21. I'm going to end the talk just a few more slides talking about how we potentially move beyond the absolute risk paradigm. So Wayne, as many of you know, and as all of you know, is a global leader in this space, has spent years and lots of effort making, I think, a really strong and compelling case for integrating proportional risk into our formulation of risk stratification. This is a graphic from a commentary that Wayne and I put together and wrote that was published last year in the European Journal of Heart Failure. And these are data from the SCUD-HEFT study, the trial that Gust and Jeannie ran here years ago. Each of these dots are a patient in the SCUD-HEFT trial, again, mapping on the y-axis rates of sudden death and rates of competing death. And this whole cohort is now organized by quartiles of proportional risk. We looked at proportional risk using the Seattle proportional risk model, something that Wayne created and has now validated in multiple cohorts. And so the blue group, highest proportional risk, red less so, green even less so, and purple lowest proportional risk. And I'd ask you to just focus on this dashed black line. So everybody who lives on this dashed black line has the same absolute risk of sudden death of 15% over 5 years. Why do we pick 15%? Because 15 divided by 5 is 3, and 3% per year is that magical threshold that everyone talks about, right? So everybody living on this line lives at that magical 3% per year threshold of dying of sudden cardiac death. And we looked in SCUD-HEFT, which is a real ICD trial, we looked at the hazard ratio of the ICD on all-cause mortality. And what we found was that at the same absolute risk, if your proportional risk of sudden death was high, the ICD cut your all-cause mortality in half. Fantastic. If your sudden cardiac death proportional risk was low, the ICD did absolutely nothing for your overall survival. And so this is in the real world, in real, sort of clearly demonstrable fashion, the consequence of identifying and the value of identifying proportional risk in patients who we think are candidates for ICD therapy. So how is this now translating into ICD trial design and how we talk to patients at the bedside? So in terms of ICD trial design, I've had the pleasure of being closely involved in a massive effort called PROFID, which is being run by Gerhard Hendricks and colleagues in the EU. This is a $20 million trial funded by the EU involving 20 countries, mainly in Europe, but also in the US. The cohort that I've been closely involved with, Predetermine, is being included in PROFID and being explicitly included in both the derivation and the execution of how PROFID is going to be deployed. And so PROFID is basically organized around this idea that our current contemporary paradigm, basically takes people at various risks of sudden cardiac death, stratifies them by ejection fraction, and deploys ICD therapy. In people with a low EF, it means over-treating people with an ICD. And in people with an EF greater than 35%, it means under-treating people with an ICD. And so the notion of PROFID is that we're going to take 1 million patients, again, over 20 countries, mainly using large-scale national observational sort of registries, as well as population-based cohorts. And we're going to use a variety of clinical characteristics, but also things like biomarkers, cardiac imaging, and genetics. We're going to use the same competing risk principles that our group and the Predetermined group has made the case for to identify a risk tool that is specific to the risk of sudden cardiac death. This is happening right now at the University of Oxford, which is the core for this study. And that risk tool is then going to be deployed as the inclusion criteria for 2 randomized controlled trials. The first trial is going to be in people greater than with an EF greater than 35%, and it's going to be a superiority trial of using this risk tool as a way to randomize patients to an ICD or not. And the other trial is going to be a non-inferiority trial of using this risk tool in patients with an EF less than 35% to evaluate the survival benefit of ICD therapy. Those trials are going to run from 2022 to 2026. And so hopefully we'll have some results in the next 5 years. Again, now integrating in clinical trial design specifically the notion of competing risk and specifically identifying patients at high risk of sudden cardiac death across the ejection fraction spectrum. Last slide here. How do we think about moving beyond the absolute risk paradigm at the bedside? So as many of you know, there's currently a CMS mandate for shared decision-making at the time of ICD implantation. The reality, though, is that implementation of that is highly heterogeneous. There's no standardized tool to deploy at the bedside, and we don't really have a great way to integrate patient-specific sort of estimates at the bedside. And so in collaboration with colleagues at the University of Colorado, Wayne and I are currently involved in an exciting study titled More Than a Checkbox, which is currently under review or will be under review as an R01 shortly, looking at integrating the Seattle proportional risk model to yield patient-specific estimates for ICD benefit. And the goal of the study is to be able to identify and deliver a tool that can be deployed at the bedside with patients to generate patient-specific estimates for ICD survival benefit. And the goal is to be able to prospectively deploy that at multiple sites, including here at the University of Washington, with evaluation of patient experience and the quality of that conversation in terms of decision-making for whether or not we deploy an ICD. So in summary, I hope in part 1 of the talk, I've made the case that that our current risk stratification paradigm, which is static and cross-sectional and predominantly uses risk inputs that are dichotomous, is not particularly helpful when we're thinking about the risk of sudden cardiac death. In part 2 of the talk, I hopefully have convinced you that competing risk matters, making the case that most of our contemporary risk markers are strongly correlated with the risk of sudden death and also the risk of competing death, and that correlated risk has real implications for how we think about designing our cardiovascular outcome trials. And in part 3 of the talk, trying to make the case to you that that we can move forward, that there are ways in which we can use both low and high cost tools, be they the EKG or whole genome analysis, to potentially improve the specificity of our risk markers. And now in an exciting way, use that paradigm, use those concepts to be able to advance both the design of ICD trials, but also improve the quality of our conversations with patients at the bedside. And so in closing, I just want to end by acknowledging, of course, that all of this work has to be done in collaboration and with the help of a lot of people. And I want to specifically thank colleagues here at the University of Washington, including Jeannie Poole, as well as April and Melissa and Wayne. I also want to give special thanks to Tom, Ray, and Nana, who have been very unselfish and giving mentors here with their time and guidance. Also want to thank colleagues at the Brigham, colleagues at sort of Cedars-Sinai, colleagues at Mass General and UCLA as well, who have been sort of really key collaborators, friends, and partners in all of this work. And also want to acknowledge some of the funding that I've gotten to be able to do this work as well. And with that, I'll pause. I'm happy to answer questions. Thank you very much for your attention and time.